It is 2 a.m. on the neurology ward, and the pager goes off for a patient who was supposed to be stable. 3 days ago, a healthy 28-year-old male was admitted with a high fever, severe headache, and profound neck stiffness. A lumbar puncture provided the critical data. The cerebrospinal fluid showed lymphocytic pleocytosis, an elevated white blood cell count driven by lymphocytes, along with elevated protein and perfectly normal glucose levels. This confirmed a diagnosis of aseptic meningitis. The medical team initiated empiric acyclovir and antibiotics. Over the next 5 days, the high fever broke. The headache dulled. His neurological exams steadily improved. By all outward clinical metrics, the crisis has passed. The patient appears to be following the exact predictable pathway for routine viral meningitis recovery. Then, on day 6, the clinical picture unexpectedly fractures. Despite his improving neurological status, the patient suddenly loses the physical ability to urinate. This graphic illustrates the result of an emergency bedside bladder scan, a residual volume of 850 milliliters. The patient is in acute, massive urinary retention. Confronted with this sudden loss of function, junior doctors often default to mechanical explanations. The first reflexive step is to assume a physical blockage, leading to an urgent urology consult and an invasive prostate examination. When that yields nothing, the physician often fears a catastrophic spinal cord compression is choking off the pelvic nerves, prompting an emergent call to neurosurgery. But the diagnostic workup reveals a complete lack of structural pathology. The prostate is perfectly normal. An emergency MRI of the brain and entire spine shows 0 signs of compression, myelitis, or structural lesions. This specific combination, aseptic meningitis, acute retention, and entirely normal imaging, points to a clinical entity occurring in about 8% of these cases, Meningitis Retention Syndrome. Missing this diagnosis leads to a cascade of invasive urological procedures and unnecessary specialist consults, causing significant iatrogenic harm for a condition that is, in reality, entirely self-limiting. To understand why this happens, we have to resolve a clinical paradox. How does surface inflammation on the brain functionally paralyze the bladder when the spinal cord remains structurally intact? We can model bladder control as this 3-lane nodal highway mapped across the central nervous system. Lane 1 originates in the cerebral cortex and the pons, generating the initial voluntary command to void. Lane 2 routes that signal down to the sacral micturition center, specifically nerve roots S2 through S4, acting as the crucial coordination hub. Lane 3 consists of peripheral pelvic nerves, carrying the final electrical execution signal directly to the detrusor muscle of the bladder. Aseptic meningitis creates acute inflammation restricted to the leptomeninges, the delicate pia and arachnoid mater encasing the brain and spinal cord. This localized meningeal inflammation acts like road construction, creating a traffic jam. It induces a transient spinal shock along the nerve roots. The signal from the brain is effectively blocked from reaching the detrusor, but without causing any physical demyelination or tissue damage. This functional, invisible roadblock silences the detrusor muscle completely. Because the disruption is chemical and electrical rather than structural, standard MRI scans appear entirely normal. We can definitively prove this functional blockade through clinical testing. Instead of relying on imaging, clinicians use urodynamic studies to directly measure the mechanical capability and pressure within the bladder itself. This urodynamics graph tracks detrusor pressure against volume in a typical patient with this syndrome. Notice the completely flat horizontal line. This confirms detrusor underactivity. The bladder is entirely areflexic. It cannot generate contractile force. If the patient had a physical blockage, like an enlarged prostate, this pressure curve would spike sharply as the muscle strained against the obstruction. The flat line rules out mechanical blockage entirely. The leading hypothesis for this specific neurogenic failure is that meningitis retention syndrome represents a mild, aborted variant of acute disseminated encephalomyelitis, or ADEM, kept in check before it can cause radiologically detectable lesions in the brain. The urodynamic data establishes the reality of the condition. The bladder is starved of neural electricity, not blocked by physical tissue. While the prognosis here is excellent, the syndrome shares initial symptoms with devastating clinical mimics that demand immediate, aggressive medical intervention. The most critical mimic to rule out is Ellsberg syndrome, a direct viral invasion of the sacral dorsal root ganglia. This matrix outlines the strict diagnostic boundaries. On the left, Meningitis Retention Syndrome requires a normal MRI and the presence of meningitis symptoms like fever and headache. On the right, Ellsberg syndrome presents with an abnormal spinal MRI, genital vesicles from herpes simplex, and critically, a complete lack of meningitis symptoms. We must also exclude the Miller-Fisher variant of Guillain-Barré syndrome, which is identified by albuminocytological dissociation, high protein but normal white cell counts in the spinal fluid. And we must rule out full-blown ADEM, which amounts itself through severe encephalopathy, seizures, and multifocal deficits visible on an MRI. Differentiating these conditions relies on the MRS rule of threes. Diagnosis mandates three co-occurring features: active meningitis symptoms, acute urinary retention, and a perfectly normal MRI. In this exact clinical context, a clean MRI is not a frustratingly negative result. It is the definitive linchpin confirming the diagnosis and cancels the need for emergency spinal surgery. When microbiology labs do successfully isolate a specific pathogen, the results point overwhelmingly to a herpes virus, specifically HSV or varicella zoster. Clinicians treat the underlying infection with intravenous acyclovir, but there is a strict pharmacological limitation. The antiviral clears the meningeal infection, but it does nothing to reverse the urinary retention. Clinicians use the bladder meningitis clock. At day 0, meningitis begins. By day 6, acute retention strikes. Weeks 2 through 4 require sustained catheterization, the window where unnecessary surgeries are often mistakenly ordered. At 4.5 weeks, spontaneous voiding returns, leading to full recovery by month 3. Internalizing this exact chronological timeline is the clinician's absolute best defense against ordering premature, panic-driven diagnostic procedures. Bridging the patient safely across that 4.5-week gap requires a strict, actionable algorithm for the ward. The singular medical danger during this period is allowing the paralyzed bladder to overfill, which causes permanent physical damage to the stretched detrusor muscle. First rule: perform a routine bedside bladder scan on every single aseptic meningitis patient admitted to the ward, asking them explicitly about their voiding. Second rule: if retention occurs, transition the patient away from a permanent indwelling Foley catheter. Initiate clean intermittent catheterization, or CIC, which drastically reduces the risk of urinary tract infections. Third rule: do not prescribe empiric steroids. Doctors often assume steroids will accelerate bladder recovery by reducing inflammation, but the clinical evidence shows they offer no benefit to the retention timeline. Fourth rule: stop all broad-spectrum antibiotics the moment bacterial meningitis is definitively ruled out by the spinal fluid cultures. The ultimate goal of management is not to aggressively cure the paralyzed bladder. The goal is to painstakingly protect it from overdistension, while the central nervous system slowly reboots itself. Surviving a 2 a.m. ward call comes down to trusting the diagnostic heuristic. Aseptic meningitis plus normal imaging plus urinary retention equals meningitis retention syndrome. The clinical response requires only 3 steps: catheterize the patient safely, reassure them immediately, and wait patiently. The most vital intervention is sitting down with a terrified young patient and explaining the timeline. You must assure them they are facing a 4-week self-limiting detour, not a permanent urological disability. Recognizing meningitis retention syndrome brings order to a neurological crisis, replacing diagnostic uncertainty with a precisely mapped, survivable waiting game.